Mr. President, ladies and gentlemen, Professor Giamarellou is sitting here in the front, but she said she's preferred to see the slides and be more able to see what we are talking. I'm honored to chair this session, just, I would say, by chance. Since 25 years, I was praising that the ancient Greeks had ideas that have not yet been realized. Can I have το πρώτο slide? And Achilles scraps his weapons on the wound of Telephos. We were all saying that's rubbish. How could this work? But a guy called Miller in Canada showed in 1981 that if you put small pieces of copper on a wound, it creates static electricity, depolarizes the wall of the bacteria so they cannot duplicate. A knowledge that does not go back to Homer, but goes even back to the ancient Egyptians. I think it is better if I can stand and talk the rest of my talk there. We will try to stay on time. Thank God we could start earlier, because as you have seen, we have changed a bit of the program. Professor Giamarellou is going to talk in the first session and not in the last, by a change that we wanted her to have her there, but she couldn't come on the morning, but now she made it possible, so we will place her where we thought from the beginning. I'm going to speak today more about surgical infections that plague the surgical patient since the antiquity. As you know, the first operation in general anesthesia was done by God himself. He gave sleep to Adam and performed the first thoracotomy, took the first rib out, and created Eve. God was himself as the surgeon, so no postoperative infection was recorded. The first operations we know go back to 10,000 BC, not always clear the indication, but definitely clear that some of them are healed. Was there open package there? Did they treat the wound just with herbs? We don't know. But at least we have here a clear healed scalp from the Hippocratic time after him, where he wrote his famous book about the trauma of the scalp, and said when we really have, and we have clear indications for the first time. They knew also, here is Aeneas, the founder of Rome, his mother Venus, and his physician Iapix, his son Julius, that if the foreign body stays in a wound, that it will be infected and the wound will not heal. So Iapix takes it out, and Venus brings dictamon from Crete to put it on, so the bleeding stops, and it's the first chemotherapeuticum recorded for wound healing. Dioscurides has a lot of herbs for wound infections, and also copper is mentioned also there. Galen made the first big mistake in saying that a wound has to suppurate to heal. Without pus, you cannot heal the wound. And so he went away from the dogmas of Hippocrates that said that ubi pus, ibi ab aqua, whenever you have pus, you have to open it. This stayed, unfortunately, for 1,300 years. And here, a picture of a medieval hospital in France, and you see patients, two in a bed next to each other, and it's clear that here we would have cross infections that were also going through the hands, but direct from patient to patient. And here, the first big reaction in Middlesex Hospital in England, in London, where they put the patient far away from each other, in between sun and air can come. They were still thinking that the air was polluting the wounds and not our hands, and we have the first clear reduction. But how is it today? We know that in the USA there are at least 2 million infections per year, 0.9 per million. The costs are immense, 600 for the total health, 240 for the hospital, and the surgical infections are $4 billion per year. This would say for Europe, it's about 6. And not only that, the additional days for a urinary tract infection, 1 to 4 days, surgical site infection, 7 to 21 days more in the hospital, pneumonia, 7 to 30, catheter-related infections or sepsis, 7 to 24. And here I would like to mention something that Professor Giamarellou has told me. Although I am an intensivist, we always learn from her that they are now catheters, they are covered with copper to prevent catheter-related infections. We had already with silver, but I didn't know that we had with copper. The mortality is between 20 and 70, or in sepsis, up to 40% today. The additional cost from a simple urinary tract infection between 500 and 800. The surgical site infection between 1,500 and 3,000. For pneumonia, 3,000 to 41,000. For sepsis, 3,000 to 40,000. And you see later data from where this infection comes, operation of normally operations that should not be infected, that they should have an infection rate under 1%, breast hernia, they shouldn't have any infection, spinal fusion, hernias, etc. Also, the infection is extremely important for the mortality. 13% of all deaths are due to hospital-acquired infection, 7% on the operate side, and 4% of all these patients are due to a bag that is now about 20 years old, the methicillin-resistant Staph Aureus, the famous MRSA, and I will show you later some data about that. The mortality of MRSA is much higher than of a simple Staph Aureus. Again, here you see between 25 and 70%, 65%. I will not stay in these ones. My other colleagues are going to say, but you see the excess cost due to Staph Aureus are 9.5 billion each year. Also, the mortality and the economic cost, extremely high. And for a 250 beds hospital, a small hospital, there are longer length of stay of 20,000 days. And if you think that for 250 mal 356 is 91,000 days of stay, the infection makes approximately 1/4. 20 patients, 1 million more. So if we can reduce 50% of the surgical infections, we can save at least 500,000. Now, when I was in Switzerland, here is the University Hospital. This is my child, the intensive care unit with 4 intensive care. Here the ORs, it was a surgical clinic with 300 beds at the time. We had a hospital epidemic with, at that time, we didn't call it MRSA, we called it methicillin, gentamicin, and dopramycin resistant Staph Aureus. It was a camel fighter from Libya that hurt his head with a camel and lost his eye, and then he was treated in Libya in a hospital, and they gave him 50,000 Swiss francs in a check and sent him to Zurich. He was operated, cleaned the face where the abscess formation was, but you see afterwards a huge epidemic with an MRSA, about 260 persons. This is the day that it started, and the white dots are the ones that were in my place. At that time, we had the old intensive care for general surgery, one with 4 beds, 2 and 2. On a Saturday morning, I find the patient with a sternotomy that was infected. It was an MRSA. I extubated him immediately and sent him isolated into the ward, but it was enough one night, from 12 o'clock midnight to next 12 o'clock on Saturday, that this one, and this one were infected. All of 3 of them died. 3 weeks later, it came there, he survived, and 4 weeks later, it came to this bed. So we knew that we were the ones that we were transporting them. You see the mortality from the first 12 patients, 8 died, 66 we learned with the time, and finally we had a mortality of about 20%, which is still around 30% also today. Also the hospitalization time up to 150 days. And then we started looking around, and you see we had carriers with multi-resistant Staph Aureus, methicillin resistant, and already in 81, Staph coagulase that was methicillin resistant, Acinetobacter, Serratia, etc. in their hands, and similar in the nose. All our personnel had multi-resistant Staph epidermidis or coagulase in their nose, and only one in their nose. But you see also Corynebacterium, you see, the 8 goes there, something has jumped, and Acinetobacter, etc. So we knew that the transmission goes through us, and we started checking. Nursing personnel, physicians, physiotherapists, X-ray personnel. From there it goes to the patient, and the patient can bring them to the home, but also the physician to the home. Patient to patient, family to patient, patient to family, and inanimate to patient. But what we knew, and this is the most important slide I have for my students, the most important carriers are our 10 fingers. The transmission goes from our blind hands from one to the other, and what we were praising also with Professor Giamarellou years, wash your hands. That's the beginning at the end of all. It's already John Comnenus that said that doctors have to wash their hands between 2 patients, but we are still not doing it. And look at some transmissions way. A surgeon with 350 consecutive cases without infections, we were making an antimicrobial prophylaxis study there. No nasal swab, we said it not. 3 weeks later, his wife came in with a life-threatening infection of the skin, and she was intubated but survived. We had cleaned, and 6 months later it came back again. We found an old carrier that was doing. Should we dismiss him, send her to holidays, change her working place? We thought eventually it's her partner that's positive. We checked the partner, they were both positive, and we had finished with the epidemic. Here it went from one patient to the other. This patient had an operation of a sigma carcinoma and came to take a lung metastasis out, and he passed it over. They were together only for 4 hours. Probably they said goodbye to each other for the operation. He had the leukemia, and as you will see, he had the resection, then an MRSA, stayed a bit longer, went home, comes a year and a half later to take a solitary pulmonary metastasis out. No problem, he went home, but on the same day, they were only for 4 hours together, a cross-infection to another. He had his splenectomy and died 4 days later. He had 2 children. So you see how the problem is. Another surgeon was a carrier of MRSA. He didn't take his fusidic acid at that time. We didn't have the bacitracin yet because it was changing his taste. He was a gourmet. After 7 days, he was again positive. We changed to bacitracin, and then it disappeared. Another one came and said, everything I touch has a wound infection. His nose was full of E. coli. We treated him with gentamicin. The infection disappeared. And you see the environmental control. The riser, the electrical that we were shaving the patient had MRSA. The telephone had an Acinetobacter. That blood gas analyzer, there we would put our fingers 200 times per day, had Serratia. The nose ointment outside, Klebsiella, the eye drops, Pseudomonas, etc. The coffee reservoir, Pseudomonas, that was multi-resistant. Now, what are the measures today? Isolation, face mask, head cover, impermeable gown, shoes, single-use instrument, disinfection, and double sack waste. I go pretty quickly. Isolation, it's important with one nurse staying in. She has to wear a mask not to protect the patient, but herself and her family, to cover her hair, because we go very easily to our head or to our nose or to our eyes. Have a gown and change shoes when you go in. This is not anymore so important as we believed at the beginning. Have instruments single use, throw them away. Disinfect the instruments when they go out and coming out, going in and coming out, and then everything that is waste, it goes in double sacks. This brings the cost extremely high, and despite that, you see how in the States the MRSA grows, and Greece is now one of the leading countries in the world. All states involved. Now, I came back to 93 to the Onassis Cardiac Surgery Center, and I knew that we have in Greece a very high amount of MRSA. You see here how it starts going up, and also here in the community. And you cannot read what it is in this map. That's why I have it. In Scandinavia, we have less than 1% in Switzerland. In Benelux, around 5%. Germany, around 15%. France, 30%. Italy and Spain, 40%. Turkey and Portugal, 50%. And Greece, over 50%. They are the pigs of Europe. Portugal, Italy, Greece, and Spain. In Greece, there were 35% in medical wards. In surgical wards, 45%. ICU. And the protecting measurements that we did from the beginning. It was easy, the hospital was starting, so we said we don't want carriers. Everybody that comes to work in is screened for MRSA, he is treated, and only if he's free, MRSA free, he can come and work. Isolating all patients that are coming from other hospitals for 48 hours, immediately check them, and suspend the isolation only if there are no multi-resistant, and they are multi-resistant free. Appropriate treatment with a clear drug. And you see from a work that we published last year, the infection rate, no more, between the last 8 years, and we have our infection rates. I don't want to go pretty to. Once there are 10 MRSAs in the respiratory, 10 surgical infections, and some others. And you see that we were able to keep our center practically MRSA free with 0.2%. But this is not always possible. if you have patients coming from the community with MRSA, if you have from other hospitals, university hospitals, they cannot do what we were able to do it in a small center. Longer ICU stays, you see the normal ones, 2 days in the ICU, 46 days, ICU mortality up to 30%, we had it 20. Now, in Greece, we have 2 other major problems that create us, and I want to show you, to tell you a terrible story that we had with the Pseudomonas. It was not multi-resistant. It came from the Children's Hospital in. Only 3 antibiotics were resistant, but very virulent. And a transplant patient got it, and we extubated him 12 hours later, and 36 hours later, he was dead. 3 days later, we had the next transplantation. The same scenario, but we knew in between that it was a Pseudomonas. We treated him accordingly, and he survived. Where was the problem? We had built a new OR, and the water that was coming underneath was the wastewater from the surgeons where they were washing their hands, was not enough running, and it was coming bubbles in the OR number 2 where these patients were operated. And the third major problems are the Acinetobacter. They are much higher now than this 1.3% because they are resistant to all antibiotics except colistin and 50% to tigersilin. Something that is revolutionary is today this machine, the Sterinis machine, where we use H2O2, hydrogen peroxide, and it sprays into the room. It needs about 20 minutes. You can enter inside. You do not have to block it completely. It doesn't smell, and it goes into everywhere that we cannot go and clean. Electrical things, computers, etc. Now let's go quickly to the copper. As I said to you at the beginning, ancient Egypt. To finish before, we found the Acinetobacter 3 months or 6 months later on the hemodialysis machine that was washed after every hemodialysis, on the corner of the screen and on the way where it was turning. So only with this machine we were able to disinfect these machines. But back to copper. Copper hammet is as hammering flakes used against wound infection, and also the malachite for eye diseases. As you see it here, you cannot read it, that's why I have it a bit bigger. In the papyrus, Ebers prescribes malachite as a dressing for burn, which has become foul, and the Edwin Smith papyrus, 100 years earlier, draws out inflammation from a wound in the breast. Here again, powdered malachite inhibits growth of Staphylococcus aureus. It was Magno that proved it, and Estes proved that cupric, carbonate, and hydroxide prevents growth of Staph aureus and Pseudomonas aeruginosa. We have several ointments. I do not want to bother you, but they exist. Sometimes they boil them for hours to get a paste or a special covering. 6 parts vinegar, 6 parts honey, 1 part of copper acetate. The coat of Hammurabi, on the other side, defends the surgeon to use for cataract operations, and we speak from 2200. They were going with a needle in and pushing the lens under the vitreous glass. And if they were using copper, some little pieces of copper would stay in the eye and he would become blind. So if the doctor was using copper needles, they should cut their hands off, is written on this codex. And as I showed you before, at the beginning, ancient Greeks, and in Homer is pretty well known. Also Hippocrates uses the flour of copper against ulcers, burned copper dust for cleaning fistulas, dust of copper against eye diseases, copper oxide to prevent suppuration of a wound, flour of copper as suppository against hemorrhoids. Ladies and gentlemen, the distance between the skin to the heart is 2 centimeters, but it took surgeons 2,500 years to reach it. In contrast, copper is used for 3,500 years, but we never knew why. I think today it is the day to show how it works and why it works. Thank you very much.
Good morning. I'd like to first start off by thanking the organizers for inviting me to speak at this very important conference. I think it's very interesting that the first modern conference on copper and health is actually taking place in Greece, where we first learned about copper and health from Homer. So I think it's rather interesting. I'd also like to first acknowledge my colleagues who have helped me with this study. Dr. Joe John, who's an infectious disease specialist, Cassie Salgado, Ken Sepkowitz, Bob Canty, Lisa Steed, and Hubert Adderway, and you're going to hear later this morning from Harold Michaels. And all of us have been involved in this study, working on this important problem. What I'm going to talk about is the microbial burden associated with commonly touched items within surfaces in ICU rooms. These are things that patients, healthcare workers, and visitors routinely encounter as they're taking care of patients or actually visiting them. So we've heard earlier some of the scary statistics. Hospital-acquired infections in the U.S. are the 4th leading cause of death. They're behind heart disease, cancer, and strokes. 4.5% of the patients admitted to a hospital get an infection. Most folks, most lay individuals don't understand what percentages mean. We have a 600-bed hospital where I work, and a 4.5% infection rate means that you have a 1 in 20 chance of getting an infection. You can do the math yourself, and you see that for every 20 patients that walk into our hospital, and we discharge approximately the whole hospital each day, you're going to see a very large number of those individuals will come down with an infection. This accounts, and again, this depends on which accountant you listen to, between $6.5 and $30 billion of real money in added healthcare costs in the United States. $30 billion is probably the real number. The federal government would like to make it lower, and the real number is probably pushing closer to the $30 billion. This is an approximate 2 million infections per year. Again, 5% of the people who acquire a hospital-acquired infection will actually die. So that's about 100,000 individuals. Again, people don't understand what these statistics mean, so you have to put it in context that really makes sense to them. They can actually live with the data. In other words, hospital-acquired infections kill more individuals in the U.S. than automobile accidents, fires, and drownings combined. Yet, if you watch the 6 o'clock news in the United States, if someone drowns, it's on the TV. If someone dies in a fire, it's on the TV. And if someone dies in a car crash, it's on the TV. If someone dies from a hospital-acquired infection, it's never on TV. Those people die, their family goes to the funeral, they suffer the loss, and no one knows. Another way of looking at it is hospital-acquired infections kill more individuals than HIV and breast cancer combined. HIV and breast cancer. HIV has a telethon, people wear ribbons. Breast cancer, they have the color pink. I mean, all of these things are for individuals that die at a lower rate than from hospital-acquired infections. Hospital-acquired infections are the dirty little secret of the planet. No one wants to talk about them because up until this point in time, we have not had an easy solution. And then we talk about antibiotic stewardship. Anyone who has ever worked in a hospital knows that this is a constant battle between the infection control team worrying about the antibiotics and worrying about the microbes that are becoming resistant to the antibiotics, parceling out the antibiotics in a very controlled manner so that you use the right ones for the right infections so that the microbes don't become resistant. Another way of looking at antibiotic stewardship is that we have not been developing a large number of antibiotics in this 21st century. In this decade, we've only developed 7 new antibiotics since 2000. In the previous decade, over 30 were developed. And as Stefan told you earlier, these microbes are becoming resistant to all the antibiotics that we have in our armamentarium. So it's absolutely frightening. So between antibiotic stewardship and not developing new antibiotics, we really have to help our healthcare workers try to combat this problem. Again, the big news is the incidence of Staph aureus. 50% of the hospital-acquired infections or nosocomial infections in the United States are attributable to Staph aureus. 64% of the hospital-acquired infections in an ICU, as well the intensivists really know, are again Staph aureus. I mean, this is a frightening number, 64%, and the outcomes are not always that good. I mean, he shared with you the statistics very quickly of how bad the prognosis is if you get a Staph aureus infection. Again, looking at actual numbers, 126,000 hospitalized patients are infected each year with Staph aureus. The question in the back of your mind is, where did they come from? Were healthcare workers that negligent in their washing of hands to transfer 126,000 Staph aureus to patients? Ask yourself the question, where did the microbe come from? Of this, 3.95 MRSA infections occur per 1,000 discharges in the U.S. each year. 5,000 folks will die as a result, and the average cost, the excess cost due to an MRSA infection, and this is across all aspects of the hospital, whether it's in the intensivist ward, cardiology ward, is approximately $21,000, which I think, again, this is using the statistics that are available to folks who crunch the numbers. But perhaps the most frightening statistic I can share with you about MRSA is how long it lasts on surfaces in the hospital environment. MRSA may last up to 180 to 360 days within the built environment. So that means on this podium, if Stefan left some of his MRSA that hopefully he did not bring with him, it could stay here for a year. And God forbid someone would bring and interact with this podia and you could pick it up. So 360 days. And the other thing that you have to appreciate, and all the healthcare professionals know this, is how small microbes are. These things are really small, and you can be the best cleaner in the world, but you have to make sure that the cleaning product reaches the microbe. And these things are incredibly small. 8% of the hospital-acquired infections are MRSA. And anytime anything makes it into the newspaper as a comic strip, you know it's real. Here is a comic that appeared in the U.S. in March of this year, and it's from Rex Morgan, MD, which is a common comic strip in the United States. And the strip reads, "What's going on, Andy? We've got an outbreak of methicillin-resistant Staphylococcus aureus." An outbreak of MRSA? Where? We don't know. And a kid just died from it this morning. That's the take-home message. We don't know where these microbes are. And I'm going to share with you our initial data from where we're finding where these microbes are. Now, finding MRSA in a patient, it's too late. The metaphor that you can use is it's closing the barn door after the horse has left. I mean, what's the point of closing a door after the animal has gotten out? And that's the issue with MRSA contamination, is you really don't want to, go after it if it's already in the patient. You're already too late. So what the Europeans have taken a lead on is this concept called search and destroy. And it's basically aggressive hand hygiene and environmental cleaning and disinfection and management of the patient, colonized and infective. And Stephen shared with us his aggressive strategy for search and destroy. I mean, it's been fairly effective, first starting out in Zurich, and he's brought that same practice here to Greece. And it's a fairly effective practice, but it's not 100%. What hasn't been asked in the modern era is what about the role of the built environment in this problem? And again, I take you back to the cartoon in the lower right-hand corner of the slide. We just don't know where the MRSA is. So this is the foundation of our study. Does the built environment present a risk to the patient? The hypothesis is the higher the microbial burden found on an object or a surface, the greater the likelihood that the patient, the healthcare worker, or visitor might acquire the microbe from that surface and then transfer it to the at-risk individual, namely the patient. So our goal in this study was to identify the highest priority components or surfaces that warrant surveillance in each of the clinical settings. Now, it's all about proximity of the surface to the patients, the healthcare workers, and visitors. For what we're going to try to do in this study is to short circuit that cycle of infection. It has to come from somewhere. You know, in the 1800s, they disproved the concept of spontaneous generation. That, of course, was the work of Pasteur. You know, spontaneous generation just didn't happen. So consequently, we have to break that cycle of infection. So the surfaces that we selected to effectively look at to see how many microbes are actually present were the bed, because after all, that's where the patient is, the tray table, the device that goes over the patient's bed in which they obtain their food or effectively place their magazines, or in some cases in the intensive care unit is where the healthcare team effectively stores stuff, whether it be soiled bed linen, whether it be medication, whether it even be the box of gloves that they are using to attach to their hands, the IV pole, the arms of the chairs that the visitors are sitting in and are being used as storage vehicles. The input device, many of our hospitals today are having keyboards, mice, as well as touchscreen monitors. And touchscreen monitors are that scary surface that actually interact with our fingers, and oftentimes we're not wearing gloves when we're interacting with those data input devices. And of course, the nurse's call button, because the nurse's call button actually does many things. It calls for help, it turns on and off the lights, and it often controls the television, both for volume and changing of the channels. So any of you who have a remote control device know that it's constantly in every male's hand, constantly flicking channels. And the women don't change the channels as much, but the men are constantly changing channels, moving from one soccer match to the other. So the meta concept that we had is the lower microbial burden will equate to a lower risk, and as a consequence, lower colonization rates, which will in turn will result in fewer infection, which in turn will yield better outcomes and lower costs. So here's the protocol that we used, and I won't bore you with all the gory details, but it's a standardized protocol in which we use a template so that we can swab the surface in an identical manner each and every time. This template is sterile. We remove a wipe material that is a polyester rayon material, and this was very important because not only do you have to liberate the microbe from the surface, it then has to be liberated from the wiped material. We also played around with diluents and moisture content in order so that it would be fairly reproducible so that we would know how many numbers that we are seeing. We did this study over 3 hospitals in the United States, and of course if you've been to one intensive care unit, you've been to one intensive care unit, because everybody's layout is a little bit different. They're all basically similar, but they're all a little bit different, and this is the layout that we have. Hospital A, you can see the data input device that we used was a touch screen monitor. Hospital B actually had a laptop computer that the hospital healthcare team was using on a routine basis. And Hospital C actually had a mouse that they were using to enter orders in for the patient. So each intensive care unit is just a little bit different. Again, we planted the samples onto a wide variety of bacteriological media, from TSA out to the fancy new chromogers, which would self-report whether or not there was MRSA present, and we incubated them for the appropriate length of time, but this is what a week's worth of Petri plates look like. This is a fair amount of work. I mean, this is one of my technicians, and this is just what we go through to do this very small study of sampling 3 hospitals in the U.S. So here's some of the early data. This is the mean microbial burden of objects in a patient's ICU room. This is data from 160 rooms. We excluded outliers that had a rank of 3 standard deviation units above the mean. And the first thing that you'll see in the blue bars is the concentration of microbes on the bed. And as you can see, it's a scary number. It's over 10,000 colony-forming units per 100 centimeters squared. So that's a fairly large number. To put it in perspective, when you go to the delicatessen in New York City and they slice the meat or the pastrami to put on your sandwich, by law, that meat slicer can have no more than 5 colony-forming units on the meat slicer. So we have on a hospital bed, which is supposed to be a clean environment, over 10,000. And of course, we excluded the outlier. We actually saw concentrations as high as 10 million microorganisms per 100 centimeters squared, which is a pretty frightening number. The other thing that you're going to see on this particular figure is that the total staphylococci really are representative of the total bacteria present. Staph and total bacteria are really pretty high. The other thing to note on the slide is the MRSA are present, as are VRE. Vancomycin-resistant enterococci are another scary group of microorganisms that cause significant hospital-acquired infections in the U.S. Fortunately for our 3 hospitals, we don't have an Acinetobacter problem at this point in time. They tend to come in waves, and fortunately, we're in a quiet period where we're not seeing a lot of Acinetobacter. If you look at the data split out, looking at the staphylococci, again, this really shows you that the chair, the visitor's chair, has more staphylococci than the nurse's call button, which was a surprising conclusion for us. But again, it shows you that the visitors could be an important component in transmitting infections to the patient or the surfaces that the patients are interacting with, and of course then to the patients themselves. MRSA are indeed present, and MRSA are indeed present on the bed at significant numbers, because you don't need very MRSA to be first colonized and then ultimately convert into an infection. If we looked at this at a frequency distribution, you can again see the high value targets in the room. And again, you don't have to be a statistician to look at these data. I asked the audience the question, if you had to pick, which objects would you pick to put copper on? And the simple answer, it's the bed. If you look at total bacteria, it's the bed. If you look at total staph, it's the bed. If you look at MRSA, it's really the bed. I mean, the bed is the object, and it makes perfect intuitive sense, because after all, that's where the patient is, and that's who you're trying to protect, and it's all about risk. You want to lower the risk of the environment in causing harm to the patient. If we again look at it, just breaking it out, looking at the total staphylococci, it's over 50%, and if we look at the MRSA, it's well over 50%. And again, the chairs, the arms of the chairs are a significant player in this, as is the nurse's call button. So if you only had to pick 3 out of the 6 objects that we had surveyed, you'd pick the arms of the chair, which are really easy to do, the bed, which is a little bit harder to do, and the nurse's call button, which is, again, a little bit harder to do because it's a multi-controlled device. Now we'll give you the data out in a tabular form, which you hopefully will be able to make some sense out. And there's a quiz associated with this data, so pay a little close attention here. The average microbial burden of an occupied ICU room over our 3 hospitals was about 16,000 per colony-forming units per 100 centimeters squared. At Hospital A, it was about 30,000, Hospital B, 16,000, and Hospital C was an order of magnitude lower at about 4,000 colony-forming units per 100 centimeters squared. Now, that was statistically significant, as the average microbial burden was significantly higher in Hospital A and B compared to Hospital C. So which hospital do you want to be admitted to, A, B, or C? Now, don't answer yet, because we need to go to the next slide. And on the next slide, we break it out with real numbers, because I was giving you absolute microbial burden. And the take-home message, again, is not all bacteria are bad. We just have to worry about the bad bacteria. So on this slide, we have a story about the bad bacteria. So we look at the average staphylococcal burden, and again, Hospital A is 24,000, Hospital B is about 14,000, Hospital C is about 4,300 again. However, when we look at the bad microbes, and we look at the colony-forming units at A, B, and C, you'll recognize that Hospital C has 197 colony-forming units, or 4.3% of their total burden is MRSA, versus Hospital A, which had the higher microbial burden, where MRSA was only 0.26%. So now I ask you, which hospital do you want to be admitted to? A, B, or C? You want to go to A, because your risk is lower at A, even though the concentration is higher. It's all about risk, because which microbe are you afraid of? MRSA, because it causes greater than 50% of the infections, more than 64% of the infections in ICUs, and so you want to go to the ICU that has a lower MRSA burden. And again, the bed rails, which effectively the patient is in contact with, you again look, Hospital A, 51%, Hospital B, 46%, Hospital C, again, it had lower concentrations. However, 93% of the total staphylococcal burden was on those bed rails. Again, which object do you want to put copper on? And again, this is just some of the conclusions here. At all hospitals, objects in closer proximity to the patient had significantly higher staphylococcal burden. Again, patients are constantly shedding skin compared to other objects in the room. And again, Staphylococcus was the predominant microbe isolated from each object, because after all, Staphylococci are effectively second layer of skin. It's what's constantly being shed from us. And the methicillin-resistant Staph aureus, vancomycin-resistant enterococci, and gram-negative organisms were occasionally isolated, but in general were responsible for less than 5% of the average total microbial burden in an ICU room, unless you look at Hospital C, where then it's really pretty frightening. So the conclusion then is a high-fidelity method for routine detection was developed, and it's fairly reproducible. Objects in closer proximity to patients had a higher staphylococcal burden, and other objects evaluated had lower total staphylococcal burden. And our data indicate that touch surfaces in ICU rooms may serve as significant staphylococcal reservoirs that could transfer microbes to patients, healthcare workers, and visitors. So those are our conclusions, but now here are our challenges. Our data indicate that touch surfaces in an ICU room may serve as a significant staphylococcal reservoir that could then transfer these microbes to patients, healthcare workers, which really is the link in the chain. The healthcare worker is the continuum, as well as visitors. So how do we translate the concentration of the inherent microbial burden into a risk factor that it poses to the patients of first being colonized by an undesirable microbe, and secondly, from developing an infection from an undesirable microbe obtained from the built environment? Now, the way medical studies are done is you typically perform an intervention to try to address this question. And here today, since this is a conference about the use of copper in healthcare, this is what we're going to report. This is our opportunity. What we know is that copper can control microbes. And again, you don't have to be a statistician to look at these data. This is the beauty of microbiology and the beauty of copper. Again, up at the top, you see stainless steel, S304, has no copper in it. You have approximately 10 million MRSA on a surface, 10 million MRSA. And at the beginning, at time 0, you have 10 million, and at 360 minutes, you have 10 million. So is stainless steel microbiocidal? No. Look over here at C197. C197 has 99.8% copper. At time 0, you have 10 million MRSA. At 90 minutes, you have 0. We're not talking 2 orders of magnitude. We're not talking 99.9%. We're talking 0, no microbes. And remember, dead bacteria do not cause infections. Dead bacteria do not cause infections. As you reduce the concentration of copper, of course, the time it takes to kill the microorganisms slows down. But as long as you have at least 60% copper, you can kill greater than 99 and then move the decimal point out 4 places, and you can kill that many microorganisms. Even with 80% copper at 270 minutes, you have no microbes. I mean, that's a really powerful message. No microbes from copper. I mean, what more could one ask for? Here's another interesting figure, and this is, again, some data that Dr. Michaels and Bill Keevil have developed, and this is from a publication in Standardization News, Standards for Metals. The top figure represents live bacteria. They're glowing in the dark. The bottom figure represents dead bacteria. They don't glow in the dark. The top metal is stainless steel. The bottom metal is copper. I mean, it's pretty night and day. And these are really easy data. Even the managers of hospitals can understand. It's night and day. You have lights on, you have lights off. And so can solid copper and its alloys be effective in the control of infectious disease? I think I've set the stage for the remaining speakers of this conference here. I think what we're going to hopefully learn at the end of the conference is that copper offers us a simple, inexpensive, and passive solution for the control of hospital-acquired infections. And I think I'm going to stop there and acknowledge my collaborators and the funding for this project. This work was supported by the U.S. Army Medical Research Material Command, and I want to thank all the folks who actually helped me out on this, especially my technical team back at the lab. And of course, none of the opinions represented in this talk are those of the United States Army. They are those of the authors of this presentation, and thank you for your attention.
Professor Giamarellou has a nickname, and she's called, I don't know if she knows it, the Queen. She will enter in the OR and will tell the surgeon, you do now that. She's not a bacteriologist that stays in the lab. She's a clinician next to the patient, and as I said, in the OR when it's necessary to be. I don't know how many times per week she's in the OR, but I would guess at least 3-4 times she's in, telling to the surgeon, now this has to go away, this is ill, and it's not the surgeon that decides, but it's her.
Okay,
and a very good friend.
Okay, that's the most important. Good morning. Thank you very much for inviting me to be with you today. Well, I'm not a pathologist, nothing to do with pathology. I'm an internist, and I am infectious diseases internist. And I want to heartily thank the president of the Institution of Copper, Mr. Moustakas, and also to thank the director, Mr. Vergopoulos, that gave me the opportunity to be with you today. Well, maybe you are going to find that I will have some overlapping with the previous speakers, but it's difficult to get rid of it since we are speaking on the same topic, actually. So, well, I'm happy that Professor Geroulanos didn't see this picture. Well, this is the medieval arts, and this is a surgery ward where you see different kind of operations are being performed. It's neurosurgery, it is orthopedic surgery, and of course the patients afterwards get a lot of infections. The nurses that were also nuns were trying to sterilize the air by what? By aromas, of course, who were in Paris. And well, I find this picture, I think it is the latest picture, in a David Copperfield book. And really it is a London hospital, and you can see what is the picture. And of course, for those who are involved in art, this is a psychiatry clinic in the Van Gogh area. And you see the curtains that divide the different rooms. So it's so easy. We know that all gram-positives, staphylococci, enterococci, different streptococci, can survive on the curtains for more than 3 months. And you know how easily it is to move the curtains and to transmit cocci in the air, and then the patient to get colonized or to get aspirated. And this is back to the 19th century in Rome, the hospital of Santo Spirito, and I think it is really surprising and worthwhile to realize that more than 100 beds are all together in the same ward. And I think this is a nice picture. And the Infectious Disease Society of America recalled this picture in a Figaro magazine, Figaro journal, that goes back to the 19th century. And this is again in Hôtel Dieu, this very famous hospital in Paris. And this is the ward that patients that were suffering from cholera were hospitalized. And because all the physicians and nursery personnel were afraid to get contaminated, this was the way they were visiting the patients. And what does the prophet say? That probably because of the multi-resistant drugs, multi-resistant bacteria, this is going to be the future of medicine and of the physicians visiting the wards where everywhere you can find MRSA or Acinetobacters or Pseudomonas. Of course, this is a dreadful mare. And this is my hospital. Of course, it is not like the Zurich hospital, but really I think from the architectural style of type, this is a nice hospital, and this is the entrance of the hospital. Of course, we do not have many rooms to isolate the patients whenever they get infected by multi-resistant bacteria, but we have a very nice infection control unit where this type of patients are hospitalized. Anyhow, well, I would like to give you some definitions because we have to separate in our mind what is a nosocomial infection and what is a community-acquired infection. And of course, a nosocomial infection is the one which is acquired after 48 hours after the hospital admission, or that is manifested at least 48 hours after that. But however, nowadays terminology has changed because we have realized that there are several invasive procedures that take care in the hospital just after your admission. It is also that patients quite often are transported from other hospitals and other ICUs. And of course, nowadays the term has been broadened. Why? Because there is a high possibility that the patient is not transferred directly from home, but before he was a resident in a nursing home. And nowadays we know that healthcare facilities are equalized with the hospitals. And a lot of multi-drug resistant bacteria are found there. And also not only that, and a lot of MRSAs, and maybe copper could also be a kind of solution for such type of healthcare facilities. So, on the other hand, we have to think that we do not have to evaluate the number of hospital-acquired infections just for the period that the patient is hospitalized. We have to count them based on what? That in the departments of internal medicine, we have to contact the patient up to 5 days after his discharge, from a general surgery after up to 30 days post-operatively, and in case that a foreign body has been inserted, we have to communicate with the patient up to 2 years after foreign body implantation. So by thinking that in my hospital the rate of nosocomial infection is 5%, this does not mean anything. You have to be correct and very strict in the way you are evaluating the possibility of a nosocomial infections. And why we are deeply concerned? We are because of increased mortality, morbidity, longer hospital days, and nowadays we are trying to get more empty beds, increased hospitalization costs, deterioration of quality of life, something very important, I think, and of course working hours loss. Always I think how sad I feel if my secretary gets sick and she has to be admitted in any type of hospital. And my colleagues already referred to numbers from the United States. That means that the translation of nosocomial infections are equal to 8 million excess hospital days, almost 100,000 deaths, and the cost of 4.5 billion cost, but those go back to about 16 years. Anyhow, this is a new, let's say, sense that 70% of all those nosocomial infections in the States are due to organisms resistant to at least one antibiotic. And if you would ask me what is happening in the Hellenic situation, I would tell you that at least in the ICUs, 100% are real nosocomial infections. And in the state, it is the fourth cause of intra-hospital mortality. And I think that I would like, just since Professor Geroulanos didn't do that, just to touch a little bit Semmelweis. I think that he was a very great figure. You see here in a stamp, Semmelweis was born in Pest in Hungary, and he died in Vienna. He was a very famous physician in obstetrics and gynecology, and he was the first to observe that in his hospital there were two different departments that women gave birth to their children. In the one, it were the physicians themselves, the obstetricians and the students that gave birth to the children, and in the other there was another department where the midwives gave birth. And he was astonished to find out that the maternal mortality rate due to puerperal fever was almost 13% whenever the physicians were involved, while it was about 2% whenever the midwives were involved. And by thinking, because we are going more than 150 years ago, he observed that the only difference between the departments were the individuals who were worked there. The first was the teaching service for medical students, while the sector had been selected for the instruction of midwives. So it was the death of a very close friend of him that gave solution to the problem. It was the death of his great friend, Kolechka, who died from an infection he contracted after his finger was accidentally punctured with a knife. When? While performing a post-mortem examination. And he found similarities in between the deaths of puerperal fever and the death of his great friend. So he made a detailed study of the mortality statistics, and he concluded that he and the students probably carried the infecting particles, because that was before Pasteur, on their hands from the autopsy room to the patients they examined in the first obstetrical clinic. So what did he do? He instituted a policy of using a solution of chlorinated lime for washing hands between autopsy work. And that was the solution. The mortality rate dropped to the, in the room that the physicians gave birth to the women from 12.5% equal to the midwives' room. And here, I think this is a poster of those years that shows Semmelweis, who is teaching the students how to use the chlorinated lime before getting into the room to give birth to those poor wives. And I think it is very important that after all those manipulations and suggestions, Semmelweis tried to widen the scope of the hand washing procedure, because he included also all kinds of instruments coming in contact with patients in labor, and he statistically documented a great success because he virtually eliminated puerperal fever from the hospital ward. And I think that since I am a female individual, I cannot skip the famous English first infection control nurse, and she is Florence Nightingale. And how did she became famous? I think it is very simple. It was just observation. Why? This famous English nurse was worked for many years in military hospitals during the Crimea War. And after that, she wrote her experience on the value of safe food, safe water, clean air, and of clean nosocomial environment. And she connected directly the influence of the clean environment with the high mortality in the military hospitals. And this is the so-called This is a hospital, believe me or not. Fortunately, nowadays, we do not encounter such kind of hospitals, but that was the picture of the military hospital of Scutari. And then, until now, and I'm sure that the English are never going to get into the euro, they are justified still to keep their sterlings. Why? Because it is this famous lady who appears on this 10, this is a 40 or 10, a 10 sterling note, and this is the famous Florence Nightingale, the so-called lady with the lamp. Why? Because she used with a lamp to check, to audit. And I think auditing is a magic word nowadays. We have to make audit. And she was auditing the ward of the wooden patients to check clean environment. Just that, soap and water. And again, from the one hand, Florence Nightingale and then Semmelweis. And believe me or not, this picture goes back only to 10 years difference. Why? Because, and I think it is jealousy. And we have to speak just for a few seconds on that. You know, when Semmelweis explained to his colleagues at the university his observations, what he discovered, they didn't believe to him. Maybe his fault was the fact that he didn't write it. Maybe he didn't like to write papers because it was obvious what he did. And then they fired him from the university. And then he was put in an asylum and he turned mad, and finally he died from an infection. Maybe his infection, because of a bite of another mad patient, gave him a similar death with his great friend Kokoschka. So, the history of nosocomial infections, of course, go back to the 50s with the severe staphylococcal outbreaks in Europe and USA. And that was the first time that the first infection control committees were established. Nowadays, we know that the prevalence in the US hospitals is 5 to 10% of hospitalized patients get a nosocomial infection. The incidence is 2 to 4 million patients per year, and the mortality is 10 to 20%. But what does that mean? That means that those are the satisfactory rates. The satisfactory rate would be 0%. What is happening in Greece? 3 exclamation marks. From 0 to 24%. And the 24% are the hospitals that they know how they have to work to survey the incidence of their nosocomial infections. And here are the happy people that they believe that they do not have any problem with hospital-acquired infections. Just a map, a table that shows which are the modes of transmission. Of course, it could be airborne, but this happens not so often. It could happen with tuberculosis, and I don't know if copper is active against Mycobacterium tuberculosis. I would be very much interested to know on that. It is, of course, aspergillus, something very important for the neutropenic host. And then it is the inanimate environment by food, infusions, and so on. And then it's the animate vectors, and the most important animate vectors, we heard to that so many times today, are the hands of the hospital personnel. And you know that several times the inanimate environment has been incriminated for hospital outbreaks, such as the air filters, the hospital surfaces, very, very important, the antiseptic solutions, the electronic thermometers, intravenous infusion, sinks, hydrotherapy tanks, room curtains. And recently in my hospital, we had a VRE outbreak, and we couldn't find the source. We have culture you cannot imagine, maybe more plates than the ones that were shown by Dr. Schmidt just half an hour ago. And you know what was the source? The plug of the electricity outside the water close, because everybody went into it, and when he made outside, probably he didn't clean well his hands, they didn't use any antiseptic, and then switching off the plug of the water close, they transferred the VREs, or they took them back and they transferred to the environment and so on. And when we've isolated this source, we were able to get rid of the epidemic. And for Greece, I would say that maybe you are deeply concerned about outbreaks, but it is not the outbreaks. Mostly, those multi-resistant bacteria nowadays are endemic in the hospitals. And it is the reservoir, it is the environmental surfaces, and it is the hands of the personnel. It is expected the inanimate environment to be colonized. No question about that. And we'd be glad to have a low rate of bacteria on all those equipments. However, still, we have to take care of our hands, because we cannot cover our hands with copper, I guess. Maybe you are going to find gloves with some mixture of glove. Who knows? So, as already was told, Staph, Enterococci, Acinetobacters cover all those inanimate environment. Now, Professor Geroulanos told us, nowadays, change of the rates of the percent of nosocomial infections have a little bit changed, because previously we thought that urinary tract infections was the first, and then surgical site infections, but by improving all those surgical techniques now, it is lower respiratory tract infections because of the ICUs. It is ventilator-associated pneumonia, and then it is bloodstream infections, primary one, mostly catheter, central venous catheter associated. And those are the different rates of gram-negative bacteria or gram-positives that you can isolate in the different hospitals. However, since we are in Greece, and I have the honor to be the chair of the Central Hospital Control Committee, Infection Control Committee at the Ministry of Health, I have to let you know that the rates are not similar with what is found in the US. If you get all blood cultures, because those are the results we have to trust, because when you culture sputum, you never know if it is colonization or if it is a real pathogen. So if we get the Greek blood culture results, first isolate E. coli, second, Acinetobacter. Third, Pseudomonas aeruginosa. Fourth, multi-resistant Klebsiella pneumonia. Fifth, Enterobacter. Sixth, Staph Aureus. The rate of isolating Staph Aureus in Greece in blood culture is around 3%. And of this 3%, 60% are MRSA. But it is only 3% if I present to you cumulatively what is isolated in Greece. So as Greeks, we would be very much interested to know how copper works against the gram-negatives. This is our main problem. This is even, we do not cover empirically MRSA a patient only if he is on septic shock. So what I want to let you know, where we are telling that the prognosis of nosocomial infections is not good, but it's much more worse if the causative microorganisms are multi-resistant to gram-negatives, to antibiotics. And you see, this is not a problem of Greece, of course. It is a problem all over the world. But mostly in Northern European countries, in the US, MRSA is what is predominating. So let me give you a picture of the resistant rates, what is happening in the Greek hospital, in the Greek ICUs, from blood culture isolates. And it is evident that Acinetobacter, which is the first in the rate, and it is a real pathogen, not a co-pathogen from which the patient is dying with, but it is a real pathogen. So here you see that the resistant rates for Acinetobacter are above 90%. And for Pseudomonas aeruginosa, even carbapenems, resistant rates above 60%. And for those multi-resistant Klebsiellas, really a nightmare, above 70% resistant rates. And there is cross-resistant. So I can't say if the strain is resistant to imipenem, I will use ceftazidime and vice versa, because there is cross-resistance. So we have to prevent nosocomial infections. This is very, very important. And I think that applying hygienic subject is also very, very important. And the most important of all in a hospital is to establish an infection control committee with objectives to implement a system of continuous surveillance, to establish the system of antibiotic policies, to establish the system of hand hygiene, maybe in the near future, to establish the system of covering what, I don't know, maybe with copper. And you know what is happening. Those are major sources of nosocomial infections and urine catheters, and this is the incorrect manner, and this is the correct manner how to evacuate the urine sacs from urine, or this message, never recap a needle, because there are problems to get wounded and to get an infection, and those are the special boxes with the yellow color that every physician can identify in the rooms to drop in the needles, and the appropriate way of using the gloves. And it is not only the surface of the nude hands, it is of course the gloves that is a major source of transmitting nosocomial pathogens. It is the way of making the beds, because you know that there is a lot of pollution, contaminated air through the bacteria that just few minutes ago were attached on the sheets, and of course the very big problems of the intensive care units all over the world. Just pictures. It's very difficult to apply those very important measures to prevent the transmission of infections. Of course, if you cannot prevent, you have to treat them appropriately. But if you have those very, very high rates of resistance to antibiotics, then better to move yourself to the prevention. And it has been found that if we are strict, if we make audit, then more than 70% of nosocomial infections can be prevented. In Greece, we have established the rule of national committees of hospital infection control that is created back in 1985 by the Ministry of Health. And this is our infection control committee. I don't know if you like it. Well, this is a happy surgeon. This is a happy internist. This is the cleaner. She looks even more happy. This is the infection control nurse. This is the engineer, very important person. This is the head nurse. And this is the person who gives money to the hospital. So I don't know who is going to offer money nowadays. And I don't want to take your time, but there are rules according to which the different infection control committees are created in our hospitals of the personnel that should belong. And what they have to do, they have to supervise the practice of the rules of hygiene. Of course, okay, I know Professor Geroulanos have never met such a picture, but it's your own design, okay? And they have to supervise the registration and continuous surveillance of nosocomial infections. They have to survey the local epidemiology of multi-resistant bacteria and antibiotic consumption, very important. And they also have to supervise and control the hospital antibiotic policies. And you know that, unfortunately, Greece is famous among its European colleagues by what? except for the high resistant rates to antimicrobial agents by the very high antibiotic overuse and misuse. And here is what is happening with the Pseudomonas among all European countries. And you see resistance to carbapenems, we have a priority with red color, or we are the very first with multi-resistant Klebsiellas, resistant to everything except for colistin. We are obliged to rediscover colistin for the Greeks' ICUs. And on the other hand, this is the overconsumption of antibiotics in Europe. This is community data, and you see that the Greece is the very first one. And if you consider cephalosporin use, 200 times more than Denmark. And if what was already said by the previous speakers, on the other hand, no new antibiotics according to the FDA data. So no truly new antibiotic after the 1990s, except for tigecycline. You know, this famous poster of the Infectious Disease Society of America, bad bags, no drugs, an antibiotic discovery stagnates a public health crisis brews. And it's true, we have arrived at the end of antibiotics, so we have to find other solutions. And I think the solutions are two. The first is the rational antibiotic prescription, and I would like to show you that since it is evidence-based medicine, that if we lower the rate of antibiotic consumption, then bacteria take back resistant mechanisms and they become again susceptible. There have been several policies suggested in the literature, and in Greece we have applied a very special form that if the physician would like in the hospitals to prescribe all kinds of advanced antibiotics, then he has to fill in this justification order form. The most important part is justify your request, and then the infection control committee, and particularly the infectious disease physician, through the Greek rule, is permitted to make audit and to cut off the ordered antibiotic. And for the hospital where the system was applied, because unfortunately it was not applied in all hospitals. For instance, before the 90s, 85% of patients were on antibiotics, and after that, 40%. And I think this is a very major decrease, followed by unbelievably lower rates of resistance, for instance, for Pseudomonas aeruginosa in the hospital where the system was applied. And it is not only the Greek system. This has been shown in several studies from the US, where, for instance, increasing imipenem increases resistance, decreasing imipenem decreases resistance, and back and so forth in all type of hospitals. And I think there is another very rational approach that means applying de-escalation in our hospitals, so restricting and de-escalations. That means that when the etiologic pathogen is isolated, change to a more narrow spectrum choice and stop all unnecessary antibiotics. Less mortality, less resistance, less superinfection, and of course, less cost. So at least for our Greek hospitals, we believe that a combination of restriction and de-escalation should be applied in all hospitals. Well, recently, the Ministry of Health, through the Infection Control Committee, the official control committee and the ministry, we published this book, and those are guidelines how to prevent and how to treat infections in the Greek society. And it is written according to evidence-based medicine and according to our very high resistant rates. And finally, to finish, it is not only the vertical selection that creates resistant bacteria, it is also the horizontal transmission from us to the environment and from the environment to us, through the hands of the medical, nursing, and assistant staff. This is another design of Professor Geroulanos that is trying to persuade us, take care of your fingers. And it is the CDC back in 2002 that for the first time spoke not only of washing your hands with water and soap, but for applying hand hygiene. And what does hand hygiene mean? That means alcoholic solution plus antiseptic, probably it should be chlorhexidine, plus glycerin. When? Before and after every contact. Usually we are doing it after, but we have to do it before and after any touch with one of our patients. And just an epilogue, I would like to say that if physicians go on prescribing antibiotics in an uncontrolled, irrational manner while allowing the transmission of multi-resistant pathogens by not properly performing hand hygiene or by not properly following the rules of antibiotic policies, then the problem of antimicrobial resistance will grow worse, and the end of antibiotic era will truly become a Greek medical nightmare. And just to finish, I would like to show this poster that was also published and found by Professor Geroulanos. You mentioned to the Emperor of the Byzantine, this is the Emperor John II Komnenos, that I don't know if he knew about copper, maybe he used it, but he was not aware. But anyhow, what he says here, and it's written in the language of those ages, and I try to translate it in English. So, but also, to every part of the Xenona was the first hospital, let's say, in the Byzantine era, will always be placed one copper-made jar, from copper, he said, full of water, and a basin for the doctors in order to wash their hands after every handling procedure dealing with one patient, whatever procedure is that. Thank you very much.